for other chronic conditions into the mainstream of the primary care community. Our second strategy is one of recovery. So Rhode Island is a leader in using recovery coaches, peer support recovery coaches, in a variety of settings. And as you heard from my colleague in Connecticut, we do that in a number of settings. So 9 of 11 hospitals in Rhode Island, in their emergency departments, have 24/7 coverage with a peer support recovery coach. So whenever somebody comes in with symptoms of an overdose, that coach is activated. The response time is 20 minutes or less. And they come to the hospital, talk with the family and the person who has just had this scary overdose experience, and invite them into treatment. They've been able to interact with over 230 people in 2014 and connect 83% of them to recovery support, with about a third of those in active treatment today. So that is something we need to build on. So we would like a 4-fold expansion of peer support recovery. We also do ride-alongs with peer support coaches in Providence and Warwick. We would like to see that in more cities and towns. And that creates a workforce issue and also a payment issue. So I have a challenge to all of the employers and health insurers in the room. This is often not paid for by health insurance, and we're going to push this issue in Rhode Island under mental health parity. This is one of the least expensive investments that can be made in really creating a sustainable change in recovery for people. And as you know, this is a disease. It's a chronic illness, and recovery is a lifelong journey. And along the way, people need support at various stages in their illness, not just at the beginning and then it's over. And these kinds of interventions have proven to be highly successful, yet are really underfunded and under-reimbursed in the commercial world, leading to me to one of my favorite phrases in healthcare: the best things we do in healthcare are free because nobody pays for them. We need to pay for things that work, and this is one of those things that work. It's a relatively inexpensive intervention. We're also going to focus on prevention. You've heard a lot today about that. Rhode Island has some of the strongest guidelines for prescribing opiates. The problem is we don't really enforce them. So while we have mandatory use of the PDMP, we haven't really seen a lot of good uptake, and we haven't really enforced that to the extent that we need to. But we will be focusing our strategic effort on the co-prescribing of benzodiazepines and opiates, which contributed to 40% of the deaths in Rhode Island in the past year. Rhode Island has the unfortunate distinction of ranking 4th in the country for the use of benzodiazepines. And the combination of those two medications and the presence of benzos in opiate deaths is alarming to us as we really look at that data. That was somewhat of a revelation. So we're going to track the co-prescribing of this, look for those reductions, and really educate our prescribing community on the harm of that co-prescribing activity. And we're going to continue to do all the other things that we need to do to reduce opiates. And another challenge to the insurance industry and to the Medicaid program in Rhode Island is we need to start paying for other types of pain management therapies that are just largely unavailable to our provider community. So our providers give the same pushback that they're giving the governor in Massachusetts and in other areas, which is, what am I supposed to do to manage pain? I've been trained to use opiates. There's not a lot else that's available. What do I do? The ECHO project has really helped with that step down. But really, I think there's so much that employers and insurance companies and Medicaid can do to promote the use of non-medication therapies that treat chronic pain. And we're just not doing enough. How many of your plans pay for movement therapy? How many of them pay for acupuncture without extreme limits. How many of them pay for meditative therapies, biofeedback therapies? These things work, but we don't do much to promote them. So our last strategy is a rescue strategy with naloxone. You've already heard a lot about that. We certainly appreciate CVS's leadership in that, as well as Walgreens in Rhode Island. Narcan can be dispensed without a prescription at those two pharmacy chains. We have a lot of distribution points throughout the state of Rhode Island. We have a purchasing program in Rhode Island. And our goal with Narcan is to really increase the rate of prescribing of Narcan when opiates are prescribed. It's very hard to evaluate who's going to be addicted, who is addicted, who else, you know. We really want to see a wide distribution of Narcan and education as to its use to rescue people from imminent death. So in a nutshell, that's our plan in Rhode Island. We are now working on the cost proposals and implementation steps. The cost proposals are due to the governor in December, the implementation steps by the beginning of the year, and hopefully we'll see these things take root and lower the alarming rate of death in Rhode Island and share these thoughts and ideas with our colleagues as we move forward. Thanks.